practice at UC Davis Eye Centers in Sacramento, California. Thank you so much to CLASS for having me to lecture on introducing keratoconus treatment and management. I have some disclosures that I speak for other companies, but this should have no effect on tonight's talk. Let's get started talking a little bit about keratoconus. Keratoconus has historically been considered a non-inflammatory condition, but with recent studies, it has been shown that there's inflammatory mediator markers in the tear film. With that said, I think it's more appropriate to consider keratoconus an inflammatory condition characterized by progressive thinning and steepening of the cornea. Keratoconus tends to be bilateral in 96% of cases, but often the severity between the two eyes is asymmetric. Onset is in early teens to early 20s, and progression continues through the 4th or 5th decade of life. Prevalence of keratoconus is 54.5 per 100,000, and incidence is 2 per 100,000. What that tells us is keratoconus is more common than we may have thought before, and this could be because we have more technology to diagnose these patients, or more understanding of the condition to detect it early. It affects both genders and affects all races. Now, we know that keratoconus is a multifactorial disease, and there are a lot of components that we still don't understand exactly what is the main driving factor. What we do know is there is a strong association with atopy in keratoconic patients. This tends to be the cause for the eye rubbing, and as we know, eye rubbing has shown to lead to progression in keratoconus. So we always educate our patients to not rub their eyes, and I often prescribe some sort of allergy drop prophylactically just to really help these patients from itchy eyes that will lead them to rubbing their eyes. There is a genetic component with keratoconus, and they've done a lot of studies with twins that have shown, familial inheritance patterns. So it's really important that we discuss with families, if there is a known keratoconic patient in the family, get everybody in for eye exams and really be testing just to make sure that no one else in the family may be developing those early signs. There also can be systemic associations, and we've seen keratoconus with connective tissue disorders, with different genetic disorders such as Down syndrome. So as you can see, there's a lot of variables that can play in with keratoconus. Now, when we look at the CLASS study, this was an 8-year prospective observational study, and it was designed to characterize the course of keratoconus and its visual and physiological manifestations. You can see that there was an N of 1,209 patients, so this was a very well done study with a lot of great data. And the key take-homes that we can see here when we're talking about visual acuity, there was a decrease in both high and low contrast acuity in keratoconic patients. Also, when looking at the corneal curvature, there was an average of 1.6 diopters of steepening of the flat meridian. There was about 20% of corneal scarring in keratoconic patients, and some of the factors that were predictive for corneal scarring were age, what their baseline corneal curvature was, if they were contact lens wearer, how the lenses were fit, and corneal staining, because as we know, if there is corneal staining, this can lead to corneal scarring. When we're looking to diagnose keratoconus, we want to do a full comprehensive exam on this patient and really pay attention to the symptoms that they're having. Are there any external signs, allergy signs of their lids? Also take into account your slit lamp findings. And then you want to make sure you're doing great corneal measurements, and that includes pachymetry. We want to know the thickness of the cornea because this is a progressively thinning condition. We want to make sure we know where they were at their initial diagnosis and how things are progressing over time. This is also a very important measurement if we're going to be recommending corneal cross-linking, which we'll get into later on. If you have a keratometer in office, great. That provides great information in terms of Ks and looking at the Myers for quality and maybe severity. Topography is great for monitoring progression. It measures that anterior corneal curvature. And I really think it's important if you're going to be managing any sort of corneal disease that you do have a topographer or tomographer in office, because although they may not be necessary to fit a contact lens, we are always monitoring the progression of a disease. So it's very important for disease progression monitoring. Tomography also gives us a little bit extra information of a posterior corneal curvature and pachymetry, along with a lot of different data that we can use in tracking these patients over time. When a patient comes in, symptoms that we want to be listening to are they saying blurry vision? Do they say their vision fluctuates? Are they saying that their glasses aren't really working for them anymore? Oftentimes with these patients, they're going to have a variable refraction, and it'll be really difficult to get to an endpoint. And so if you're seeing this in office, or if you're doing a retinoscopy and you're seeing scissoring on that retinoscopy, this can be a warning sign that you might be dealing with someone with keratoconus. Also, they tend to have, like we mentioned, decreased contrast sensitivity and acuity. And one of the most common things you'll hear is ghosting or monocular diplopia. Oftentimes you'll have patients read a chart or look at a letter and they'll tell you there's multiple letters, or there's multiple kind of a halo or a flame shape above that letter. And that's because of the higher order aberrations that come with keratoconus. So this is very common to hear with patients. Some signs to look for. We don't talk often about Rizzuti sign, but this is a great sign to look for. If you illuminate the cornea from the temporal side, the light comes to a conical point within the limbus nasally. You can also look for signs with retroillumination. If you have the patient in the dark, you can use a direct ophthalmoscope, shine the light towards them, and as you can see in this upper picture, you get that oil drop appearance. And that is very characteristic with keratoconus. You'll also see scissor reflex on retinoscopy, and that kind of tips you off that some things are irregular with the cornea. And at the end stage, late stage, more severe keratoconus, you'll see Munson sign. And that is when a patient looks down, it's almost the V shape that is created in that eyelid, just because that cone is kind of pressing down towards the lid. And so that's usually seen in more severe keratoconus. Some slit lamp findings that you'll see are apical thinning, and that's typically going to be inferior. So if you have a slit beam and you're scanning across the cornea, you'll see that there's a deflection where it looks thinner across the cornea, and you might have more prominent corneal nerves. Void striae is very common, but not necessarily seen in everybody. And this is when you have vertical lines that almost look like stretch marks within the posterior stroma or decimes. Fleischer's ring is very common as well, and this is that iron deposit at the base of the cone. As you can see in this upper photo, it's very faint, but it's almost this brownish orange arcuate iron depositing, and that's seen in about 50% of cases. I tend to see this a lot more often than 50%, but that's something to look for as well, and very common in keratoconus. And finally, corneal scarring. So when you look at the cornea, if you're seeing corneal scarring, it looks irregular, maybe web-like scarring, this can be an indicator for keratoconus, and it's normally seen at the apex. So if you're scanning with your slit beam, you see kind of some steepening there and having scarring, this can be seen with or without contact lens wear, actually. Going into topography and tomography, so we've got topographers that are reflection-based, and these are the most common that you'll see with the placido disc ring pattern that's projected on the cornea. We extrapolate to get those height measurements when we're using a reflection-based system, and the accuracy is going to be really dependent, really big driver on the tear film. Is the eye really dry? Are they fixating correctly? Are they looking upward? Sometimes we can get some false images if the patient's not fixating in the right spot either. So those are really important things to look for. If the patient's eye looks dry, make sure you put some lubricating drops in there before you're taking these images. And I would say that's true for topographers or tomographers in general. Good ocular surface or good tear film will give us better images. Now, with tomography, you can get projection or elevation based, and these measure the height of individual points. And, with this, you'll get some extra information like pachymetry and posterior corneal curvature, which is really important especially in an early keratoconic patient that may not have a lot of these signs that we talked about or these slit lamp findings. having this imaging where we can see what the back surface of the cornea as well as the front surface of the cornea looks like is really important. And you'll see these type of systems in ophthalmology practices where they're performing refractive surgery or any type of corneal surgery, just because it provides a lot more information on the overall shape of the cornea itself. Some commonly used maps that you'll see are the axial sagittal map, and this is a dioptric value type of map that shows, the color map across the cornea. It's not going to be as detailed on the curvature as the tangential type of map. That's more accurate, more precise with the corneal shape. But I really think what's one of the most important maps to look at is that elevation map, because that really will tell you the location and the height of the cone. And when you're fitting contact lenses, a lot of times where that cone's located is really going to play into what type of lens you're going to use or what type of shape you're going to use. So I think that map's really important to have. And if you have access to an instrument that also gives you the posterior corneal curvature, if you start to see that tongue-like pattern, that could be suspicious for an ectasia. So as you can see in this photo, that's that tongue-like pattern that we're talking about, where it's irregular on that back surface, and that's truly an indicator that something is not regular with the cornea.
Un comprobado líder en la práctica de lentes especiales y ojo seco. Cuando la precisión importa.
Also, a common map that you'll use is the thickness map, and you'll want to look at where that thinnest location is of the cornea and does that correlate with that area of steepening. Oftentimes, if you're looking at a thickness map and there's a deviation of greater than 30 from one point to the other, that's another little red flag that maybe there's something irregular going on, and it could be an ectasia. So really pay attention to those maps because they'll tell you a lot. These are just some of the maps. Like I said, the instruments now have so much other information that you can access and really get a lot of information for progression tracking as well. So let's go into some of the indicators that you'll see with keratoconus. Like I mentioned with keratometry, if you have a keratometer, and this is even true with like the Placido disc maps, when you're scanning the patient's eye, you'll see some distortion in the Myers, and that's usually an indicator that, hey, something's irregular with that cornea. If you see a flat meridian that's greater than 48, that's also an indicator for keratoconus as well. When you're looking at topography maps, really pay attention to the bow tie pattern, because if you see a large asymmetry between right and left eye with that bow tie pattern, that kind of gives you another wake up of something might be irregular. And like we said, keratoconus tends to be asymmetric, so take a look at those. Also, if you're comparing the inferior to the superior dioptric power difference, if it's greater than 1.5 diopters, that tends to indicate keratoconus. So take a look at those numbers on your topography maps. And finally, if the bow tie pattern is bent or skewed towards, the horizontal meridian, as you can see in a lot of these photos here where it's a little bit asymmetrical, you're seeing bending on that bow tie, that's usually an indicator of keratoconus as well. And again, when you're looking at those thickness maps, pachymetry less than 500, we really want to be suspicious, especially if they've never had any sort of refractive surgery. Now, when we go through characterizing keratoconus, we start with nipple cone, and this is going to be your smaller size, less than 5 millimeter, kind of central paracentral steepening. Then we go into oval cone, which is a flatter, broader cone, and it's typically inferior temporally. And then keratoglobus, this is going to be your broad protrusion with diffuse thinning, and this tends to be more limbus to limbus. You're going to get thinning that's worse in the periphery. If this is a congenital keratoglobus, that tends to be bilateral, and it's not usually as progressive as keratoconus, and you really want to just monitor for perforation because of that thinning. If it's acquired form keratoglobus, though, this is really, we're talking our severe keratoconic patients that are going to be more difficult in general for fitting. Pellucid marginal degeneration is going to be your typical kissing doves, crab claw appearance that you see here. You'll have that purple band of inferior thinning or flattening, and a lot of times you hear the term beer belly type of steepening, but this kind of map where you see with that kissing doves is very common with diagnosing pellucid marginal degeneration. Now, form frus, keratoconus, is very important, especially when we're talking about patients that are coming in and maybe you're wanting to consider LASIK. With form frus keratoconus, this is a subclinical disease, and what that means is there's no recognizable clinical findings. So this could look like a normal cornea, but then they become ectatic post-refractive surgery. Or it could be a little bit of an abnormal cornea, but it doesn't really have all of those clinical signs that we talked about earlier in regards to keratoconus. So things you really want to be paying attention to are those risk factors, those kind of red flags that we talked about. Do you see an asymmetric bow tie? What is that IS value when you're comparing the inferior dioptric value to the superior? Is it greater than 1.5? What does that posterior corneal curvature look like? Is it uniform, or are you seeing irregular astigmatism on that back surface and it maybe just hasn't manifested yet on the anterior surface? And then what does that corneal thickness look like? If any of these seem at all suspicious to you, this would not be a person that you would want to be performing any sort of refractive surgery or anything like that. And these are people that you're going to want to be following and repeating this testing over time, just to see if there is any change, because it could be keratoconus and you just don't have those clinical findings that you were expecting to find. Now, when we're planning on fitting contact lenses, the big portion of this talk, things to consider with contact lenses are their age, their severity of their keratoconus, how is their dexterity? Is this an older patient that maybe have a harder time with a lot more steps, and what does their current vision look like? Do they have scarring? What is their past contact lens experience? Have they tried other lenses and they didn't work and failed? What were the reasons why they failed? These are all things you want to consider and kind of talk through with the patient before you get started fitting the patient. And just remember that the goals for contact lens management for keratoconus is to improve their vision. These patients are going to have a very hard time in glasses. Only the mild cases are really able to stay in glasses. And even then, as progression occurs, glasses become a way backup option and not going to be superior vision at all. So we really want to get them excited about contact lenses and let them know that we have a lot of options available to help improve your vision, to help reduce some of those aberrations that are causing the ghosting or triple vision. And you really, as a provider, just want to make sure you're seeing them back closely and monitoring, because we want to make sure they maintain good ocular health through their life. When you're choosing that initial lens, you want to think of the severity of their keratoconus. Look at their corneal diameter, because a lot of times these fitting guides with some lens designs want to know what is that corneal diameter. That helps kind of drive your decision. You know, if someone's having a very severe keratoconus, we might need to go larger just to kind of support that weight of that lens, help with centration. Do they have corneal scarring? Have they ever had a corneal transplant? This might change the type of design that we choose based on that. And other things to think about, which a lot of times we forget, is lid anatomy. Do they have really deep set eyes? Do they have really small eyes? Do their lids completely close? These are all factors to think about, because they're going to play into how well they see, how well they do with the lenses. So really take these things in mind. Also, pingueculas, other kind of elevations on the eye. How large are the pingueculas? What are we dealing with? Because some of these obstructions can make contact lens fitting a little bit more complicated. So we really want to take this all into account in the beginning to make sure that we provide the best options for the patient so that they're successful. And finally, think about, do they have other ocular diseases that are being managed? Do they have glaucoma blebs? That plays a huge factor as well, because we don't want to be putting them in a lens option that may complicate something different, like a glaucoma bleb. I really think it's really important on that initial consult or initial fitting that we are really educating our patients as much as possible. Oftentimes, patients come, we fit them in lenses, we we're just trying to get as much as we can because it's a long visit, that we forget that this is a lot of information for patients, and we really want to make sure that they're well educated on the process, really define patient expectations from the get-go regarding visual demands, regarding comfort, and make everything very clear when it comes to cost. Because a lot of times cost is an issue for patients, and if we don't provide them the cost, tell them why things cost what they do, the value in that, what type of warranties are involved with the lenses, patients don't like to feel surprised. I think educating on the front end and making sure we're all on the same page is also just as important as a very comfortable lens fit. So first option that we have, and it's usually going to be indicated for more mild cases, would be a custom soft lens. Some of your patients that you're thinking about are mild keratoconus. Keratoglobus could potentially be a good candidate. Pellucid marginal degeneration, just because sometimes these patients do better in spectacles to begin with pellucid in the early stages, and so they may do well with soft contact lenses. And then those that are GP intolerant. I will say for those that are transitioning from a GP lens to a soft lens, just make sure that they are aware that their vision may not be the same quality of vision that they had in that GP lens. But a lot of times, if comfort is the ultimate goal for the patient, they're willing to compromise a little bit on the vision to get into that comfort. Some disadvantages of these custom soft lenses are you may not get the same type of optical correction that you get in a gas permeable lens, and there's always that risk for microbial keratitis. So advantages with a custom soft lens is it's a custom lathe, so you have a lot of options on how to manipulate the lens. We have extended base curves and power ranges. You're able to manipulate the center thickness, modify the peripheral curves, and they're available even in high oxygen materials, which is great. They do have aberration control, and typically these lenses are going to be fit from a diagnostic set. We're not usually empirically ordering these soft lenses. Usually you have a fit set, putting lenses on the eye, let the patient experience it, seeing how they're fitting, seeing how you're going to have to modify things, and always make sure you follow fit guides.
Whether you're helping your patients with the daily irritation of dry eyes or combating other ocular surface diseases, Boston Sight Sclero has the data-backed science and experience to help them see the world through a whole new lens.
Gas permeable lenses are great options for, quality vision for those patients. Usually if someone's not going to be a good candidate for a soft lens, we're offering them a gas permeable lens. And so for a corneal GP, potential candidates would be a new contact lens wearer or someone that's mild to moderate where, kind of your slam dunk keratoconus patient. I know that right now, scleros have become very popular, but I will tell you a huge chunk of my practice is still in corneal GPs, and they are doing fabulously with minimal maintenance and loving their lenses. So don't forget that corneal GPs are a really good option for patients, and cost, if cost is a factor, these are great options for those patients as well. They're going to get good vision, very easy to handle. So those patients we were talking about dexterity issues, this tends to be easier for them. They can use their fingers, pop them in, take them out, less kind of issues with handling issues on insertion and removal. And like I mentioned with cost, if they were to lose a lens or it pops out, replacing these lenses are a lot more less costly than something like a scleral lens or maybe a hybrid lens. Some disadvantages though is you do have to educate them on that initial lens awareness in the beginning. And I like to use the term lens awareness. I don't like to say your eyes are gonna hurt or anything like that. And if you've never had a corneal GP in your eyes, stick one in the next time you go back to the office so that you can see what lens awareness is, so that we can have a little bit more appreciation of what we're putting our patients through and what we're expecting them to do. But I always like to tell them, if you can just first day wear that lens for 1 hour and build up an hour each day till you're full time, that's great. If you feel like you need to take a couple days at 1 hour and then build up, that's fine. As long as you're wearing it every single day to get your lids used to the lens, I'm happy. And, that's great. The other disadvantage is sometimes these can be decentered. So if you have a very inferior cone, they can kind of decenter downward. And again, lenses can pop out with these. And if they pop out, sometimes it's hard to find. So keep that in mind as well. When we're choosing a diameter, a lot of times it's based off of, severity or where the location is, and smaller diameters are going to be better for those nipple cones, central, oval, smaller apertures. Larger kind of intralimbal size are ones where maybe you need help with getting better centration. So these can help with giving you more centration. You're going to get that added comfort because it's a larger size, and you'll get that larger optic zone. So if you're getting kind of ghosting halos and you think it might be related to the optic zone, an intralimbal will give you that larger optic zone. Remember that as we increase the base curve, we tend to decrease the optic zone over time because we want to minimize any chances for getting bubbles within that kind of peripheral pulling that occurs as we become more severe keratoconus. And the secondary curves are still going to be significantly flatter. And a lot of times you don't even need to think about these things as long as you consult with the labs, let them know. They will guide you through these changes, but I always kind of like to know, why are we changing things? So this gives you a little bit added information on why we're doing what we're doing. Some disadvantages of having those intralimbal lenses are you are more prone to having some inferior edge standoff just because of the size. And it might be a little bit more difficult to get alignment with these just because of the size of them as well. So we're dealing with more plastic, more surface area, and so you might put the situation where you get areas of heavier touch. So overall, when we're fitting lenses, we want to fit by sagittal depth. We're thinking, the deeper the cone, the deeper the height of the lens that we need. You really want to avoid heavy bearing to decrease the risk of scarring. We don't want to be the cause for scarring. So you really don't want to have heavy bearing on the cornea like this photo below. And we really want to provide them with high oxygen materials. We have so many options now for high oxygen materials that there's really no reason that we should be putting someone who has keratoconus or a corneal transplant or anything in something that's less than these higher oxygen materials. Now, fitting philosophies, we want to go through the history of what the fitting philosophy were from before to now. In the past, and I'm sure you've had tons of patients come in your office where they're told that they were putting corneal GPs so they would press their cone to prevent it from getting worse. And we know that that's false. We know, from CLEC study and just from clinical experience that we do not want to bear on the cornea because that can lead to staining and scarring. What we do want is this nice 3-point touch where we have, feathery touch in the center and 2 other points of bearing that kind of help support the weight with a nice peripheral edge lift and the lens moving easily and getting tear exchange. We do not want heavy bearing on that cone. The other fitting philosophy is to start with apical clearance, and I'm sure you guys have heard of FIDACL, but if you haven't, that means the first definite apical clearance lens. And what that meant is you would start with the base curve that was equal to this deep K, and you would slowly flatten that K until you got, your first kind of soft bearing onto the cornea where it didn't fully bear, but you got that 3-point touch. And you wanted just to make sure that you didn't get any sort of peripheral seal off. You wanted to have good edge lift on that lens. Another option that involves a corneal GP would be a piggyback system, and this is a GP lens that's fit over a soft lens with a high DK. And the goal for this usually is because you either have centration issues or a patient is uncomfortable, they're having some 3/9 staining, and no matter how you manipulate that lens, you're still having just a few issues here, and you don't want to have scarring. So by putting that soft lens on there, the goal would be to get better comfort, better centration, and prevent any sort of scarring. We don't need to take that soft lens power into account because only about 20% of that power of the soft lens is taken into the full lens system. The only time you would really be concerned is if you're using like a high plus lens or a high minus lens for some reason where you thought maybe that would help center the lens better. and then you would have to take that into account. But otherwise, if you're using like a -0.5 soft lens just as your piggyback, you really don't have to take that power into account for the whole system. Hybrid lenses are a one lens system with gas permeable center and soft skirt. So it's like that next step from GP or from piggybacking, where we don't need to do piggyback, it's all inclusive in one. And this is designed to have apical clearance with a light touch at the junction. It is a reverse geometry design, so you get kind of that lift off of the cone and off of the mid-periphery so that you can really vault over a lot of corneal irregularities, including keratoconus. The advantages are you get a higher DK material now with the newer hybrid designs. You get high DK with the GP and the soft skirt. But again, you need to follow the fitting guide, and you do need to have this fit set in office to put the lens on the eye. If you were to empirically order, you're still going to have to kind of manipulate that. So I'd really encourage you to have a fit set and really follow the fit guide for this. Now, scleral lenses, which we've heard a lot about, and I'm not going to go too far in depth in there, but I did want to bring them up because they're a great option for keratoconus. Candidates would be people with advanced irregularity, and they don't necessarily have to have advanced irregularity. They can be moderate or mild, but these are people to think about. We want to vault that cone, pellucid marginal degeneration, people that have had intacs or they had a corneal transplant, corneal scarring, and again, patients that are intolerant to those corneal GPs. Remember that with sclerals, they are lenses that are great to use for our patients, but they do involve a little bit more complexity. There's going to be more, follow-up chair time involved, more education for our patients, and there is more maintenance for that patient. So handling for insertion and removal, keep that in mind. Really review your solutions, the non-preserved salines, the things that are approved for potential coatings that you add on there, and take in mind if a patient has really small eyes or if they're having dexterity issues, this may be a more difficult option for that patient. So keep that in mind. It's not that they're not a candidate, but you always want your patients to be successful. So if we can try to put them in maybe a smaller size scleral or something like that, that may help with some of those concerns that we have with smaller apertures. And then remember that costs are significantly more with sclerals, so that's something to keep in mind. And if you have a patient that maybe doesn't have vision insurance that will cover a lot of this, you just want to make sure you're educating on the front end and reviewing the importance of this lens and why you're prescribing it and the value, and also making sure they're clear on cost expectations. Scleral lenses vault over the cone and they align to the bulbar conjunctiva. Diameter, really these larger diameter lenses is what makes them really comfortable, and you get great centration, and they don't move, all over the place with blink. They're really stable. And this chart just kind of depicts what, a scleral is, and depending on the different diameters, some of the terminology, but overall, just remember sclerals were vaulting with the cornea. Now, I wanted to make sure that if you weren't familiar with some of this newer technology, there is scleral profilometry available. And this is a device that measures topography of the cornea and the sclera, and it allows us to do a really customized approach to fitting scleral lenses, where we can almost completely empirically design a lens based off the data we get from these instruments. And the advantage to a practitioner and to a patient is efficiency. We're gonna have a lot less chair time. We're gonna be more accurate at the initial lens fit. And ultimately, patients love that they don't have to come back 10 times, and they're gonna get a really comfortable lens, maybe more accurate alignment from the get-go. So these are great devices to have those additional measurements. Just really quickly, there's an S-map, which uses fluorescein, and you look into different gazes, up, down, straight ahead. These images get stitched together, and that's what provides that end result for you when designing a lens. There's the Pentacam CSP. This is software within the Pentacam. It is an upgraded software, and this does not require fluorescein. All the images are taken in primary gaze. You might have to have the patient turn their head left or right to get a better kind of positioning for some of those quadrants, but the images can be covered up to 18 millimeters. And this is great because it's not lens specific, so you can use this software to design a variety of scleral lenses from a lot of different manufacturers. And finally, the Eaglet ESP. This offers, topography of cornea and sclera. It generates those height maps. This one can have diameters of up to 20 millimeters on your scans. And again, with this one, not lens specific, they work with a lot of manufacturers, and they're even having lens designs for corneal GPs and hybrids coming down the road, even potentially ortho-K. So this is another great instrument if you were wanting to have this in your office to help just make things go quicker. And I've had the opportunity to work with a lot of this instrumentation in conjunction with everything else to help design these custom lenses. And it's been fabulous for patient care and for that first lens almost being, all the changes done on the first lens. This is an example of on the Eaglet ESP when you put in the scan, you would pick a drop down of a manufacturer that you wanted to use, and then you can send all this information directly over to the lab without having tabulation errors, and they can help you with designing that lens. Now, really important, I do think that with all of our keratoconic patients, we need to be talking about cross-linking. And with cross-linking, it's important to know the thickness of their corneas, because anybody that has less than 400 microns usually is not a good candidate just because of that UV exposure. It can cause damage to other structures within the eye if you had a corneal thickness less than 400. But the methods that are available there to help with stabilizing the cornea so that we don't see, dramatic progression in these patients would be epi-on and epi-off. And epi-on is transepithelial. Epi-off is the standard protocol that has been done in a lot of studies. So really important that we educate our patients about this option. Right now, not all insurances are covering it, but even still, we should be offering this to our patients, especially for noticing progression, so that we can prevent them from becoming really severe keratoconus patients and hopefully keeping them halted so they don't end up needing a transplant or, developing scarring or other issues that can come from this progression. Now, resources for you, there are a ton, and these are, some that I listed for you just in terms of management for keratoconus, how to get information on where to start. GPLI, Gas Permeable Lens Institute, is a great resource. They have all these fitting calculators, information, articles. So that's a great resource for you for fitting hard gas permeable lenses on patients. The Scleral Lens Education Society is another fabulous resource, and they've got patient videos on there for education on insertion, removal, a lot of answers to a lot of common questions that patients would have. The International Keratoconus Academy is another great resource, and National Keratoconus Foundation is a great resource for your patients and for practitioners. Equipment that you want to have in office, you want to have fitting sets. Fitting sets are good to have. A lot of things now are becoming more readily available for empirical fitting, but some of these aren't. So make sure that you have the fitting sets that you need to do over refractions or to do fittings of these patients. And a tomographer. It's definitely an essential to have one of these instruments because we're monitoring progression of a disease. So that's very important. Scleral profilometry is a bonus, and like I said, this technology is great, so hopefully even if you don't have it in your office, you've had the opportunity to either visit someone's office that does or go to a conference now that we're going to be back in person, hopefully soon, to play with some of these instruments and see just the technology that's there, because it's really, really helpful with patient care, and I've had great success with it in my office. OCT and anterior segment cameras, these are all extra bonuses that would be great to help you fitting. This photo here shows, the sagittal depth with the clearance there in the cornea and the contact lens. So if you have the ability to have an OCT, it really is helpful for troubleshooting if you're not sure if there's touch, if you're still trying to gauge, how to assess clearance with slit lamp. It's a good way to cross-reference yourself. And it's also great because you can take these images and send them to labs for consultation if you need additional assistance, and they can kind of see what you're seeing a little bit better. Photos tell a lot. And again, patient education is key. So make sure you're telling your patients, as much as you can, writing it down. They've done, I'm in a support group, and one of the things the patients say is, I love the offices that write out information, or they have a printout that has all these websites for me to go to and get information, because patients really do want the information. And when they go home, we've told them so much information that they feel overwhelmed, they can get lost. And we know that if they switch some of the steps in their routine, it could be really costly for them if they lost a lens, or if they broke a lens, or if they used the wrong solutions and they damaged the lens. So really important to educate our patients and take that time, maybe train a tech in your office to be the educator, or have a lot of handouts, but patients appreciate it. So really quick, let's do a few case reports here. This is a corneal GP patient, 14-year-old male, recently diagnosed with keratoconus. You can see the refraction here, and they were about 2150 in the right eye, 20/20 plus 2 in the left eye. And as you can see, the right eye was the more severe eye. Fit this patient with corneal GPs, and you can see the parameters here. And these were their final lenses. And with these lenses, they were seeing 20/20 in each eye. So you can see that just taking a corneal GP, putting on the eye, can be great answer for a keratoconic patient. Another case report with a post-surgical ectasia patient. This is a 67-year-old female. She had radial keratotomy in 1993, and her complaint was her vision was fluctuating all the time, blurry, dryness in both eyes. She's using tears, and her glare is worse at night. And so you can see with her refraction, it's okay vision. It's not great with her glasses, but these glasses are not solving some of these other symptoms the patient's talking about. She had tried corneal GPs, hated them. They were not comfortable. She did not like them at all. She wanted to be fit with sclerals, and that's what she was referred to me for. And so based off of her corneal diameter, fit her in diagnostically with scleral lenses. And these are her final lenses, and you can see she's seeing 20/20, thrilled with her vision, thrilled with her comfort. She's able to wear them all day. Now, really quick, I just want to leave you with some key take homes on billing and coding. And this is by no means is a billing and coding end all be all, because we could do hours on billing and coding. But I want you to remember that the 92072 is what you're going to use for keratoconus. And it's a bilateral code. And so this is the definition of it. And just if you're using medical insurance when you're billing this code, it does not cover follow-ups. So you want to make sure every follow-up you are billing it to the medical insurance. Now, if you're using vision insurance, excuse me. If you're using vision insurance, that has a global period. And so that is not going to be billed every single time. As you can see, there's a lot of lens materials that can be used for keratoconus. So just make sure you're using the right code depending on the type of lens that you selected for that patient. And our final case, just so you can kind of see what a typical keratoconic patient would look like and what a billing would look like. So we have 34-year-old male referred for keratoconus. He's had it for 3 years, corneal GPs in the past, and he's just, having discomfort. He can't wear them for longer than 5 hours, and they shift around, and he's having some lens awareness, so he's ready to be fit into something new. So we decided to fit him in a hybrid lens, and as you can see with a new keratoconic patient, you're going to bill the exam, you'll bill the refraction. If you're taking any sort of pictures for whatever reason, you're going to bill that, as well as your topography, pachymetry, your eval code, the 92072, and then the lenses that you're going to use. And these are all made up fees. These are not real fees. This was just for demonstration purposes. But get really good at coding for your keratoconic patients because you're going to be just as much of an advocate for them as they are. And if you're not billing correctly, you'll be missing out on income, but also patients could get denials just from us not writing letters for medical necessity or not billing appropriately. So just follow up on this aspect. Not going to go into it a lot, but I did want to bring this up because it's a very important aspect in your overall treatment for these patients. Thank you so much for having me. If you have any questions, please feel free to email me at this email here. Y si hablo español, solamente hice la charla en inglés porque es más fácil para mí. Pero si tienen preguntas y solamente hablan español, me pueden mandar un mensaje por el correo electrónico y yo te puedo mandar también. Muchas gracias. Thank you so much for having me.